Chapter 13, Three-Dimensional CT Basic Concepts. The purpose of 3D imaging is to use the vast amounts of data collected from the patient by volume CT scanning to provide both quantitative and qualitative information in a wide range of clinical applications. Qualitative information is used to compare how observers perform on a specific task to demonstrate the diagnostic value of 3D imaging. Quantitative information is used to assess three elements of the technique: precision or reliability, efficiency or feasibility, and the accuracy or the true detection of the 3D imaging procedure. As far as history goes, in the 1970s, motion display of the ventricles by using biplane angiography and then commercial introduction of CT renewed interest in medical 3D images, since it was very clear that a stack of contiguous CT sectional images can generate 3D information. This then resulted in special hardware and software being developed for the production of 3D images and the development of algorithms for 3D imaging. By the early 1980s, many CT scanners featured 3D imaging software as an optional package that could be purchased. Several researchers began using 3D imaging in the early 1980s for craniofacial surgery, orthopedics, radiation treatment planning, and cardiovascular imaging. In 1991, the first textbooks on 3D imaging were published, including the Atlas of Craniofacial Deformities illustrated by 3D CT images. There are four coordinate systems that relate to the CT scanner: the display device, the object, and the scene. I refer to figure 13.1 on page 311 of your book. These coordinate systems include the scanner coordinate system, the display coordinate system, the object coordinate system, and the scene coordinate system. The most familiar system is the XYZ, which is the scene coordinate system, also known as the Cartesian coordinate system, as it is sometimes referred to. The Cartesian coordinate system is where the X, Y, Z axis are positioned at right angles to one another. This means they are orthogonal to each other. The width of an object is described by the x-axis. The height is described by the y-axis, and the z-axis describes the dimension of the depth and adds perspective realism to the image. The coordinate system allows the description of an object by measuring distances from the point of the intersection, or the 0 point. Distances can be positive or negative from the 0 point, and the images can be manipulated to rotate about the three axes. This rotation occurs in what is called 3D space, and computer software helps the observer to view 3D space by showing the front, back, top, and bottom of the object, which provides a perspective from the observer's vantage point. The technologist can transform 3D space in four ways, which is noted on table 13.2 on page 312 of your book. These include image space, object space, parameter space, and view space. Modeling is the generation of a 3D object using computer software. Modeling uses mathematics to describe physical properties of an object, and there are several modeling techniques that are utilized. Extrusion is one of them. It's a common technique, and this is where computer software is used to transform a 2D profile into a 3D object. An example of this is when a square is changed into a box. It can generate a wireframe model from a 2D profile. The wireframe is made of triangles or polygons, often referred to as polygonal mesh. Wireframes were common during the early development of 3D display in medicine. In the next step of modeling, a surface is added to the object by placing a layer of pixels and patterns on top of the wireframes, and the tech can usually control the different attributes of the surface. Shading and lighting also add a sense of realism to a 3D object. Shading helps determine the final appearance of the 3D object, and in shading there are several algorithms that are used, and each of them has their own set of disadvantages and advantages. Some of these include wireframe shading, flat shading, glurad shading, and Phong shading. Lighting helps us to see the shape and texture of the 3D object. While there are many different lighting techniques utilized in 3D imaging, Ray tracing is the most common. This is where a mathematical ray is sent from the observer's eye through the 2D computer screen to pass through the 3D volume that contains opaque and transparent objects. Take a look at figure 1312 for an illustration of ray tracing. Rendering involves a computer program converting anatomic data collected from the patient into 3D imaging. There is surface rendering, and then there is volume rendering. In surface rendering, it uses only the contour data from the set of slices in 3D space. And in volume rendering, it makes use of the entire data set in 3D space. Volume rendering actually produces a better image than surface rendering since it utilizes more information. However, the downside is that it takes a long time and requires a more powerful computer. There are 3 classes of 3D imaging, which include slice imaging, projective imaging, and volume imaging. Slice imaging is the simplest method of 3D imaging. An example is multiplanar reconstruction, where you can generate and display coronal and sagittal images from the axial images. Although MPR is now on every scanner commercially available today, multiplanar reconstruction does not produce true 3D images, but it does produce 2D images displayed on a flat computer screen. Projective imaging is the most popular 3D imaging approach, but it still doesn't offer a true 3D image. It produces an image somewhere between 2D and 3D. Surface and volume rendering are examples of projective imaging. In volume imaging, this does produce a 3D image, but don't confuse this with volume rendering. Some volume imaging methods include holography, stereoscopic displays, anaglyphic methods, varifocal mirrors, synthesizers, and rotating multidiode arrays. 3D imaging can refer to the categories of operations, which includes pre-processing, visualization, manipulation, and analysis. 4 steps are needed to create 3D images. These 4 steps vary depending on which imaging modality is used to acquire the data. But we will describe each step using CT as the data acquisition method at hand. In data acquisition, slices or sectional images of the patient's anatomy are produced. Data can be acquired by a conventional CT scanner or in a volume with a spiral helical scanner, as we've discussed. We've already discussed data acquisition in depth in previous chapters, so I won't go into it in much detail in this chapter. One of the problems of using a conventional scanner in regards to 3D imaging is that the certain portions of anatomy can be missed because motion caused by the patient's respiration can interfere with scanning or be inconsistent from scan to scan, which then can lead to inaccurate generation of the 3D and multiplanar images. This can make the final 3D image have the appearance of a step-like contour known as the stair-step artifact. In volume data acquisition, volume of tissue rather than a slice is scanned during a breath hold, which means that more data are sent to the computer for image reconstruction. And one advantage to volume data acquisition in regards to 3D imaging is that more data are available for 3D processing, which then improves the quality of the resultant 3D image. Creation of 3D space or scene space is another step necessary to create a 3D image. The voxel information from the sectional images are stored in the computer, and all the information collected from the voxels that make up each scan slice goes to the computer for image reconstruction. The result of image reconstruction is 3D space, and all the image data is stored here. Processing is another step of 3D imaging. There are 2 types, voxel-based and object-based. With voxel-based processing, this makes determinations about each voxel and decides to what degree each should contribute to the final 3D image. An example of voxel-based is the MPR technique, where the computer scans the 3D space and then locates all the voxels in a particular plane to produce that particular image. In object-based processing, this uses the voxel information to transform the images into a collection of objects with subsequent processing concentrating on the display of the objects. Object-based processing involves several processing methods to produce a model, which this model is called an object model or object representation. The processing of an object model into a simulated 3D image involves steps such as segmentation, which is a processing technique used to identify the structure of interest in a given scene. It determines which voxels are a part of the object and should be displayed, and which are not and should not be displayed. Thresholding. This is the method of classifying the types of tissues, such as bone, soft tissue, or fat, represented by each of the voxels. The CT number is used for assigning thresholds to tissues. An object delineation. This portrays an object by drawing it. It involves boundary and volume extraction and detection methods. With rendering, this is a stage when an image in the 3D space is transformed into a simulated 3D image to be displayed on a 2D computer monitor. It requires specific hardware and software. And the fourth step is 3D image display. The 3D simulated image is displayed on the 2D computer screen. So we've lightly touched on surface rendering and volume rendering a few slides back, but we will discuss them a little bit more in depth now. Surface rendering, also known as shaded surface display, involves two steps. The surface formation, which involves contouring, and rendering follows the surface formation and is then intended to add photorealism and to create the illusion of depth in an image. This is what makes an image appear 3D on a 2D computer screen. The advantage to surface rendering techniques is that they don't require a lot of computer power because they don't use all of the voxel information in 3D space to create the 3D image. They only use the contour information. But, however, this does result in poor image information content. These two pictures are just examples of surface rendering images. Volume rendering is more sophisticated and it produces 3D images that have a better image quality and provides more information compared with surface rendering techniques. Volume rendering uses the entire 3D data set, remember, and it is what makes it more, requires more computing power and is more expensive than surface rendering. It involves two steps: pre-processing, which involves segmentation or classification, to determine the tissue types contained in each voxel and to assign different brightness levels or color. 3 tissue types are used for voxel classification, and these are bone, fat, and soft tissue. Rendering is another stage of volume rendering, and it involves image projection to form the simulated 3D image. One popular method is ray tracing, which we touched on a few slides back. Remember, ray tracing is one of the mathematical rays sent from the observer's eye through 2D computer screen to pass through the 3D volume that contains opaque and transparent objects. Processing of image data from 3D space can also generate intensity projection renderings. This includes sliding thin slabs. Sliding thin slabs consist of thick slices from thin slices, reducing the noise level and possibly also improving the visualization of structures. The algorithms for sliding thin slabs include average intensity projections, or also known as AIP, maximum intensity projections, and minimum intensity projections. For the AIP, this is intended to create a thick multiplanar reconstruction image by using the average of the attenuation through the tissues of interest to calculate the pixel viewed on the computer. Take a look at figure 13.8 in your book to see how the AIP can affect an image. Maximum intensity projections, or MIPs. This is when the only tissue with the greatest attenuation will be displayed for viewing by the observer. These originated in MRI exams but are now common in CTA exams, and they use less than 10% of the data in 3D space, which then requires less computer processing hardware and also takes less time to process the volume rendering algorithms. The MIP computer program renders the 2D image on the computer screen from the 3D data set. This allows rotation back and forth of an image and viewing of complex structures. However, it does have some drawbacks. In the past, it didn't account for depth, and now depth-weighted MIP images can be used to solve this issue. Another con is that it cannot show superimposed structures, and it can generate a string of beads artifact. A minimum intensity projection is known as a MINIP, and this ensures only tissues with minimum or lowest attenuation will be displayed for viewing. This is the least used of all three projections, and it is useful in defining lesions for surgical planning or detecting subtle small airway diseases. And these pictures just give examples of a MINIP right here and a maximum intensity projection right here on the right. Virtual reality imaging. Virtual endoscopy is the creation of the inner views of the tubular structures. A virtual endoscope is a graphics-based software system used for simulating endoscopic exploration inside a 3D image. In virtual endoscopy, a 3D image acts as a copy or a virtual environment representing the scanned anatomy. With the assistance of computer-based rendering tools, a virtual endoscope produces endoluminal surface views inside the virtual environment similar to those from a real endoscope. It allows for the unrestricted exploration, and when a real endoscope is used, the patient may feel some discomfort during the actual procedure. And this obviously doesn't even occur in virtual endoscopy because there is no physical device even used. 4 fundamental requirements must be taken into account in CT virtual endoscopy, which are data acquisition, image preprocessing, 3D rendering, and image display and analysis. Data acquisition is the first step in virtual endoscopy imaging, and the tech must carefully select the scan parameters to be used for creating the data set. The parameters represent a trade-off between dose and image quality. In the image preprocessing phase, this is the next step after data acquisition, and it is intended to optimize images before they are subjected to further processing and analysis. Image segmentation is an important step in preprocessing, and it prepares the objects for rendering. This can be done semi-automatically by the operator or automatically without the operator. Volume extraction is another preprocessing tool where the 3D surfaces are extracted from a volume. 3D rendering is the next step. For virtual CT endoscopy, surface rendering and volume rendering are used, but surface rendering is not best suited for use in virtual CT endoscopy because of the production of partial volume averaging artifacts. Volume rendering provides the best results because it generates optimal visualization of the anatomy, minimizes partial volume artifacts, and adds lifelike reality to the images. In the image display and analysis step, this requires powerful computer workstations to handle the data acquisition and the advanced visualization processing operations. Virtual CT endoscopy includes image analysis techniques that allow the user to assess images with a wide range of software tools. These pictures are an example of images generated from 3D colonoscopy exams. A unique feature of the CT endoscopy tool is compositing. This is also known as 4D angiography. This is volumetric imaging technique that displays bone, soft tissues, and vessels at the same time. It provides 3D images with a fourth dimension, which is opacity. It is used in pre-endoscopic lesion screening and to explore hollow anatomic structures. 3D Navigator is another tool, and this allows the user to fly around the outside of the anatomy. And Osirix is another tool yet. This is for use in image fusion techniques for hybrid imaging. It is used to navigate through image data sets generated by hybrid modalities such as the PET CT scanner, multi-slice CT scanners producing dynamic cardiac images, and MRI scanners producing functional cardiac images. So as 3D and VR imaging technologies expand and become more commonplace in medical imaging and in radiation therapy, it is likely that the tech will play a more in-depth role in image processing and analysis techniques. So rad techs may actually need to expand their knowledge base of understanding 3D concepts. And educational programs may need to offer specific courses to prepare their students to perform 3D imaging and post-processing. The tech and the radiologist must work as a team for quality 3D images. And the best way to do this is to have effective communication.